firstly, the vision of the NHI, and the Honourable Minister, spent a lot of time explaining the energy and the vision behind that. So in the NHI preamble, they talk about distributing resources in ways that are more equitable, more efficient, and more effective. We want a system that's less fragmented, that is less divided, that is more, where there's more solidarity, more cohesiveness, more of a joint vision and a joint energy. But it's interesting also that there's also efficiency and effectiveness that are at stake here. Currently, of course, we don't have that health system. We have a health system that's broken, fragmented, divided, and often wasteful. Both the private and the public, there are evidence of waste, of inefficiency that need to be addressed to progress towards a health system that we can be proud of. Of course, there are two large rationales, also evident in the language of equity and efficiency and effectiveness, two important motivations for pursuing more equity, more equality in the health system. The first is the social justice rationale. It's a human right to have access to health, and also, at the moment, health functions as a channel through which a poverty trap can occur. We know that if individuals do not have decent access to healthcare, this can affect their health, which in turn will affect their productivity and thus their labour market incomes, causing individuals and communities to be trapped in poverty. And then also, just from a growth and efficiency perspective, we can also argue for greater health equality because of the tragedy of wasted human potential. The first part of my presentation, as I said, would look at the problem. When I talk about insurance, it's more or less equivalent to medical scheme membership, even though I'll be using the term insurance. The first graph that I want to show you looks at how insurance coverage varies across wealth quintiles. And you can see there, it is a very stark picture. By and large, insurance coverage is concentrated in the top quintile, that is the top fifth of our wealth distribution. Who are the people who have health insurance in South Africa? If we look at who constitutes that 17.5%, the first point to note is it's the employed. As soon as I get a job, my likelihood to have insurance goes up from 17.5% to 50%. If you get a well-paying job, it goes up much, much higher to 81%. Parallel to that, we find that having a university degree is also highly correlated with having insurance. The converse, who are the households who don't have insurance? Is it because these households might be very young, might be very healthy? That is not what we find. Fortunately, in the General Household Survey in 2009, Stats SA decided to ask this question explicitly to households. And what we find is roughly 9 in 10 of the households who did not have access to health insurance say that it's simply an issue of cost. Health insurance does not provide better utilization. That's not where we see the big gaps. And we can look at different ways to approach this. This is from the National Income Dynamics Survey, just looking at whether you went over the past year, went longer ago than over the past year but did go, or whether you've never been. And we don't find any evidence of large gaps across the insurance divide. Where we do find the large gaps is in access to higher levels of care. We find that if we ask respondents about where they went over the last year, and if they went, a far larger share of the insured went to hospitals. It's easier for them to access hospitals, and also a far higher share of the insured were able to see a doctor. Insurance buys you shorter waiting times and higher levels of satisfaction. What we also are worried about, and that we've heard from other speakers, is the inequalities of the public health system. Here, I'd like to refer to some of the tuberculosis research that we've done, which shows that just as case studies, for instance, when we look at stockouts, we find that stockouts are more prevalent, more likely to occur in poor districts. But that's just the first problem. The second problem is that we find that the very poorest members of a society or community, if they go to the clinic and there's a stockout, they don't go to clicks and they don't go to another clinic. They go without medicine. So we see a higher impact on the TB cure rate in poor communities than we see in other communities. We all know that one of the places where we lose TB patients is that many patients test for TB, but then they don't come back to collect their test results and start on treatment. And we wanted to understand that problem in more depth because only qualitative work has been done on this so far. What we find is the largest impact is based on vulnerability. Females and the poor are the people who tend to delay coming back or to not come back. Moving over to the solution and trying to engage with what the NHI provides us, I think there's a lot in the NHI to be excited about. I agree with a lot of the press that it is still quite broad brushstrokes. The first positive about the NHI is the shared platform of providers. As a researcher, I've often tried to look at public and private hospitals using CASASA data, trying to use household surveys to compare the two systems. But our system is so divided that often we actually have different researchers working on the private and the public. We have different data sets for private and public. And I think we really can only start to understand the deficiencies of the system if we have shared data. So as a researcher, I'm very excited about the shared data. Then one of the most often cited benefits of the NHI is definitely the GP contracting. I think that can be seen as a very important component of it because it provides an avenue to build social solidarity, providing a real benefit for middle-class taxpayers. And for that reason, I think it's important to start with that component of the NHI as soon as one can, so that the NHI can generate the positive energy and the solidarity that it needs to really work over the long term. The danger of capitation is that it can lead to underservicing, so it's vital to build in performance metrics as is currently planned. These estimates that I provide here are accurate percentage point estimates of the impact of moving from no coverage to coverage. And what you can see there is there's a large utilization response, which I think is quite interesting and suggests that even though utilization, we don't see a large gap between the insured and uninsured in terms of utilization, because of the greater health needs of the uninsured population, the poorer segment of our population, there might still be pent-up demand. And we might still see a massive utilization response if we provide access to high levels of care, such as doctors. So we need to think very carefully about how we manage access to doctors and how we ration that to ensure that those who need to see doctors will be those who see doctors. What is also promising about the NHI is it provides more carrots and sticks than we have at the moment in the health system. Included in the bill is, of course, certification that will happen through the Office for Health Standard Compliance, also accreditation that will happen through the NHI fund. And then there's also often references to performance management, so including performance expectations in the contracts. The 6 criteria, so the idea is that you need providers will need certification, and over above the certification, they will need to meet 6 criteria. Those 6 criteria is related to the range of services that they provide, the mix of professionals that they have in their team, adherence to healthcare referral networks, the data repository, submitting your data to the data repository as required, adherence to the national pricing regimen, and then something that I want to talk more about, and that is adherence to treatment protocols and guidelines. Standardized patients or simulated patients have been used extensively in training medical students. But recently, over the past 10 years, the World Bank and other health economists and clinician teams have started to use standardized patients to get into the provider-patient interaction. So the difficult ethical concerns to navigate, but it amounts to sending an actor or community member into the clinic with a script of what illnesses or symptoms they need to communicate, and then they need to record, they're trained quite well, they need to record what questions they were asked and what tests were administered. And when we compare our experience in the field in the Eastern Cape at 20 clinics in East London, is that there was a very large discrepancy between what facility managers thought were happening in that patient-provider interaction and what, based on exit interviews and based on our standardized patient score sheets, what was actually happening. In our assessment of protocol adherence and protocol adherence, we can get to the truth. We'll be shifting a lot of paper, and we won't see equity, and we won't see effectiveness in our health system. I think that is one of the things that maybe as a researcher, coming with that perspective, is the most important contribution that I would try to make with my inputs into the NHI bill. In closing, just a few overarching thoughts. I think at the moment, because the NHI needs to cater for private and public providers, it's very likely that the yardsticks that we use to assess the accreditation criteria and the yardsticks that we use to assess performance might be set at quite a low level. Also, a lot of the oversight and monitoring functions will be new, so we need to ensure that we can have the capacity. Without that, I'm worried that we won't achieve the vision of the NHI, and that all of this energy will not be directing us towards greater solidarity and better health outcomes. It's very easy, I think, once the NHI is up and running, to become complacent. And I think it's important that we work against that, and we commit ourselves to incremental and continuous improvement of the standards that we set for providers. In terms of local responsiveness, in the NHI you see this trade-off between centralization and decentralization, and that's an incredibly difficult debate that we find across different service delivery areas, because on the one hand, local responsiveness is crucial. We want to respond to local need. We want to empower and capacitate local leaders to find local solutions. What we find by and large is that decentralization leads to larger gaps. Books don't get ordered, medicine stockouts are greater. Because in the provinces where poverty is rifest, we often also have issues with financial management skills, issues with finding staff at these clinics. It will be important to strengthen the role of community engagement, community boards, clinic boards, and the really important factor here is empowering these local entities with information. And because of that, I'm quite a vocal advocate for mobile surveys to see whether we can ask some of the visitors to clinics very specific questions about the experience and what went right and what went wrong, similar to our exit interviews. And I think it's vital, not just because it will provide a mechanism through which we can invigorate and improve our health system and have a unified vision, but also because I think activating these communities and giving them this vision, this shared vision of a better, more cohesive health system involves them. It makes them part of the reform of the health system. And in that way, it is not just a health system reform, but it becomes part of something much broader, a dialogue about what type of country we want to be and what type of country we want to become. Thanks.